I'm about to tell you something that could genuinely save your life, and the frightening part is that it has been hiding in plain sight for decades. You have seen it written on every blood pressure reading you have ever had, two numbers, one on top of the other, numbers that doctors mention casually, that nurses read out loud almost automatically, numbers that most people glance at, nod, and move on from without a second thought. But here is what almost nobody ever explains clearly, especially to people over 60. One of these numbers is far more dangerous than the other as you age, and the number that is silently killing more seniors is often not the one people worry about. I am Dr. Sandra Miller, and after more than 20 years as a cardiac surgeon, I've spent my life inside operating rooms holding damaged hearts in my hands, operating on arteries destroyed by decades of uncontrolled pressure, seeing the aftermath of devastating strokes that could have been prevented, and sitting across from families asking the same heartbreaking question: why didn't anyone warn us? What I am about to share with you is not theory, not opinion, and not fear-mongering. It is based on decades of large-scale research involving millions of patients, and it is information that every single person over 60 needs to understand. By the end of this video, you will know which blood pressure number poses the greatest threat to your heart and brain, why that number becomes more dangerous with age, and exactly what you need to do starting today to protect yourself. This may be the most important 15 minutes you spend this year, so stay with me. To understand the danger, we need to start with clarity. When that cuff tightens around your arm, it measures the pressure of blood pushing against the walls of your arteries, but blood pressure is not constant. It rises and falls with every single heartbeat, and that is why you see two numbers. The top number, called systolic pressure, measures the maximum force inside your arteries when your heart contracts and pushes blood forward. This is the moment of peak pressure, the surge, the equivalent of a powerful wave crashing into a seawall. The bottom number, called diastolic pressure, measures the pressure when your heart relaxes between beats, the calm between waves, when the heart muscle rests and refills with blood. So when you see a reading like 150/90, it means the peak pressure during contraction is 150 millimeters of mercury, and the resting pressure between beats is 90. For decades, medicine treated both numbers as equally dangerous. If either one was high, you were labeled hypertensive and treated accordingly. But as researchers followed millions of people for decades, tracking who had heart attacks, who suffered strokes, who developed heart failure, kidney disease, or dementia, and who died from cardiovascular causes, a very clear pattern emerged, and that pattern becomes stronger the older you get. To make this real, let me tell you about two patients. The first was Margaret, a 73-year-old woman who came to see me for a routine cardiology evaluation. Her blood pressure that day was 165/70. Margaret was pleased, even proud. She told me, "Dr. Miller, my bottom number is perfect. I worked so hard to keep it under 80. I know my top number is a little high, but my doctor said as long as the bottom number is good, I don't need to worry too much." I wish I could tell you that advice was harmless. 6 months later, Margaret suffered a massive stroke that left the left side of her body paralyzed, her speech slurred, and her independence gone. The cause was not her diastolic pressure. It was years of elevated systolic pressure silently damaging the blood vessels in her brain while everyone celebrated a good bottom number. The second patient was Robert, 68 years old, with a blood pressure of 128/95. Robert was terrified. He had read online that diastolic pressure was the real killer, that it meant the heart was under constant strain. He feared a heart attack was imminent. We ran a complete cardiac evaluation, including stress testing, echocardiography, and coronary calcium scoring. His heart was strong, his arteries showed minimal plaque, and his overall cardiovascular risk was far lower than he imagined. Yes, his diastolic pressure needed attention, but his immediate danger was nowhere near Margaret's. Two patients, two patterns, two completely different outcomes. This brings us to the question you came here to answer. Which number is more dangerous, systolic or diastolic? The answer depends on age, and for people over 60, the research is overwhelming. Large studies such as the Framingham Heart Study and the MREF-IT trial, along with many others involving millions of participants, have shown that after age 60, systolic blood pressure is a far stronger predictor of heart attacks, strokes, heart failure, kidney disease, and death than diastolic pressure. In fact, systolic pressure is often 2 to 3 times more predictive of cardiovascular risk in older adults. Researchers also notice something critical. As people age, systolic pressure tends to rise while diastolic pressure often stays the same or even falls. This creates a condition known as isolated systolic hypertension, and it is extremely common after 60. For years, this pattern was dismissed as normal aging, but we now know that assumption was dangerously wrong. Isolated systolic hypertension is not benign. It is one of the strongest risk factors for stroke and cardiovascular disease in older adults. Treating it has been shown to reduce stroke risk by up to 40% and heart attack risk by up to 25%. These are not small benefits. These are life-saving differences. So let me be very clear. If you are over 60, the systolic number, the top number, is the most dangerous number on your blood pressure reading. It is the number that predicts whether you are likely to suffer a heart attack or stroke, and it is the number that demands serious attention. That does not mean the diastolic number is irrelevant. It matters, but in a different way, and understanding that distinction is critical for safe treatment. To understand why systolic pressure becomes more dangerous with age, you need to understand what happens to your arteries. Arteries are not rigid pipes. In youth, they are elastic, expanding with each heartbeat and recoiling between beats. This elasticity absorbs pressure and protects organs from constant force. As we age, those elastic fibers break down and are replaced with stiff collagen, calcium deposits form, and atherosclerosis develops. The arteries become stiff. When the heart pushes blood into stiff arteries, they cannot expand, so pressure spikes sharply. That spike is systolic pressure. Meanwhile, the resting pressure may stay normal or drop. The result is high systolic pressure pounding the organs with every heartbeat. This repeated force damages the brain, kidneys, heart, and eyes, creating micro-injuries that accumulate over time. In the brain, this leads to tiny vessel damage, silent strokes, and ultimately vascular dementia. In the heart, it causes thickening of the heart muscle, leading to heart failure. In the kidneys, it destroys delicate filtering units, leading to chronic kidney disease. This is why systolic hypertension is so dangerous and why ignoring it is a mistake that can cost lives. You now understand the foundation. This is where many people are misled, even by well-meaning professionals, and where treatment decisions can accidentally cause harm if the full picture is not understood. Diastolic pressure, the bottom number, represents the pressure in your arteries when your heart is resting between beats. This resting phase is not unimportant. In fact, it is during diastole that your heart muscle itself receives most of its blood supply through the coronary arteries. This means diastolic pressure plays a critical role in nourishing the heart. However, the danger of diastolic pressure is not symmetrical to systolic pressure as you age. In younger adults, elevated diastolic pressure is a strong predictor of future cardiovascular disease. It often reflects increased resistance in the smaller blood vessels and chronic strain on the heart. But after 60, the physiology shifts dramatically. As arteries stiffen, systolic pressure rises while diastolic pressure often stays the same or declines. This creates a situation where lowering blood pressure too aggressively can push diastolic pressure dangerously low, even while systolic pressure remains elevated. This is one of the most misunderstood and dangerous treatment traps in senior health. When diastolic pressure drops below approximately 60 millimeters of mercury, the heart may not receive enough blood during its resting phase. This can lead to chest pain, reduced exercise tolerance, shortness of breath, and in some cases silent myocardial ischemia, where the heart muscle is starved of oxygen without obvious warning signs. Many older adults with very low diastolic pressure feel fatigue, weakness, dizziness, or brain fog, and they are often told these symptoms are just part of aging, when in reality, they are signs of inadequate perfusion. Another critical concept you must understand is pulse pressure, which is the difference between systolic and diastolic pressure. For example, a reading of 160/70 produces a pulse pressure of 90. A wide pulse pressure is a marker of severe arterial stiffness and is independently associated with increased risk of heart attack, stroke, cognitive decline, and mortality. This means that a low diastolic number does not automatically mean safety. In fact, when diastolic pressure is low while systolic pressure remains high, it signals advanced vascular aging and increased risk. This is why focusing only on the bottom number can be dangerously misleading. Many seniors proudly report that their diastolic pressure is perfect, while ignoring a systolic number that is steadily damaging their organs. This misconception has cost countless people their independence and, in many cases, their lives. As a cardiac surgeon, I have seen patients arrive in the operating room with hearts thickened and weakened by decades of elevated systolic pressure, while their medical records repeatedly noted acceptable diastolic readings. This is not a failure of intelligence. It is a failure of explanation. Another factor that complicates blood pressure management after 60 is orthostatic hypotension, a sudden drop in blood pressure when standing. As arteries stiffen and the nervous system becomes less responsive with age, the body's ability to rapidly adjust blood pressure when changing positions declines. If diastolic pressure is pushed too low through aggressive medication, standing can cause a sudden reduction in blood flow to the brain, leading to dizziness, blurred vision, weakness, and falls. Falls are not minor events in older adults. They are often life-altering or life-ending. A single fall can initiate a cascade of decline, including fractures, loss of mobility, hospitalization, infections, and permanent loss of independence. This is why blood pressure management in seniors must balance two competing priorities: reducing long-term vascular damage from high systolic pressure while preserving adequate perfusion to the brain and heart. This balance is not achieved by blindly chasing a single number. It requires individualized targets, careful monitoring, and an understanding of how aging physiology changes the rules. Research has consistently shown that while systolic pressure above 140 significantly increases stroke and heart attack risk in older adults, diastolic pressure below 60 increases the risk of adverse events, especially when combined with high systolic pressure. This is why modern guidelines emphasize controlling systolic pressure while avoiding excessive lowering of diastolic pressure. Unfortunately, many people are still treated using outdated frameworks that do not fully account for this nuance. This leads to situations where medications are increased to chase an idealized systolic target, while diastolic pressure silently drops into a dangerous range. Patients are then told that dizziness, fatigue, or confusion are unrelated or inevitable, when in reality, they are red flags. Understanding this helps you become an active participant in your care rather than a passive recipient. You are not being difficult if you ask your doctor how low your diastolic pressure is going, whether your pulse pressure is widening, or whether your symptoms could be related to overtreatment. Now that you understand the danger of focusing on only one number and why systolic pressure carries greater long-term risk after 60 while diastolic pressure cannot be pushed too low, we need to answer the question that naturally follows. What should your blood pressure actually be at this stage of life, and why the old universal targets no longer apply? For decades, medicine promoted a single ideal number, 120/80, as if the human body did not change with age. But aging profoundly alters vascular biology, nervous system response, kidney regulation, and medication metabolism. These changes mean that the perfect number for a 45-year-old can be inappropriate or even dangerous for someone in their 70s or 80s. Large population studies over the past 2 decades have forced the medical community to confront this reality. When researchers began separating outcomes by age rather than averaging everyone together, a clear pattern emerged. In adults over 65, especially over 75, the lowest mortality and best functional outcomes consistently occurred at systolic pressures slightly higher than the traditional ideal. This does not mean high blood pressure is safe. It means that overly aggressive lowering can cause more harm than benefit in certain populations. The concept is not about allowing uncontrolled hypertension, but about optimizing perfusion while minimizing vascular injury. Studies such as the SPRINT trial initially suggested benefit from intensive systolic lowering, but it is critical to understand who is included and who is excluded. Many frail seniors, people with prior strokes, diabetes, advanced kidney disease, or frequent falls were excluded. When later real-world studies included these populations, the results changed. Mortality curves formed a U-shape, meaning both very high and very low blood pressure increased risk, with a middle range offering the best survival and quality of life. For many adults over 70, that range often falls between 130 and 145 systolic, with diastolic typically maintained between 65 and 85. Below this range, the risks of dizziness, falls, kidney injury, and cognitive decline increase. Above this range, the risks of stroke, heart failure, and vascular damage rise sharply. This balance point shifts further upward with advanced age and frailty. A robust 68-year-old who is physically active may tolerate lower systolic targets without symptoms, while an 82-year-old with arthritis, slower reflexes, and reduced kidney function may experience severe consequences from the same numbers. This is why individualized blood pressure targets are not optional after 60, they are essential. Another factor that cannot be ignored is medication sensitivity. As we age, the liver and kidneys clear drugs more slowly. Medications remain active longer and at higher effective concentrations. A dose that produces mild blood pressure reduction in a middle-aged adult may cause excessive lowering in an older adult, especially overnight or when dehydrated. This explains why many seniors feel worse after intensifying blood pressure treatment even when their numbers look better on paper. Symptoms such as morning weakness, mental fog, unsteady gait, and fear of standing are often dismissed as aging when they are actually signs of overtreatment. Orthostatic hypotension deserves special attention here because it is one of the strongest predictors of falls and mortality in older adults. A blood pressure that appears acceptable while seated or lying down can become dangerously low upon standing. This happens because aging blunts the baroreceptor reflex, the system that rapidly adjusts heart rate and vessel tone when posture changes. If medications lower baseline pressure too far, the body cannot compensate quickly enough and blood flow to the brain drops. This is why checking blood pressure only in one position is insufficient in seniors. Measuring lying, sitting, and standing pressures provides critical safety information. A drop of more than 20 points systolic or 10 points diastolic upon standing is a warning sign that treatment may need adjustment, regardless of how good the resting numbers appear. Blood pressure management after 60 must also consider cognitive health. The brain is exquisitely sensitive to chronic underperfusion. While high blood pressure damages small cerebral vessels over time, excessively low pressure reduces blood flow needed to sustain neuronal function. Imaging studies have shown that older adults with very low systolic or diastolic pressures may experience accelerated white matter loss, which is associated with slower thinking, impaired balance, and increased dementia risk. This reinforces the principle that optimal blood pressure in seniors is not the lowest achievable number, but the number that preserves brain, heart, and kidney perfusion while minimizing vascular injury. This is where many people get confused because they believe treatment means immediately adding more medication or forcing numbers down as fast as possible. In reality, effective blood pressure control in older adults follows a layered approach, beginning with lifestyle interventions that directly improve vascular function and only then adding medications when necessary. One of the most powerful yet underestimated strategies is sodium reduction. As arteries stiffen with age, they become more sensitive to salt. This means that the same sodium intake that caused minimal pressure changes at 40 can raise systolic pressure significantly at 70. Studies consistently show that reducing sodium intake to around 1,500 to 2,000 milligrams per day can lower systolic pressure by 5 to 12 points in older adults, sometimes more. This is not achieved by simply avoiding the salt shaker, but by reducing processed foods, packaged meals, canned soups, breads, sauces, and restaurant meals, which account for the majority of sodium intake. When seniors adopt a low-sodium, whole food-based eating pattern, blood pressure often improves within weeks. Another critical factor is potassium intake. Potassium helps counterbalance sodium and relaxes blood vessel walls. Diets rich in potassium-containing foods such as leafy greens, beans, avocados, yogurt, and certain fruits have been shown to improve systolic pressure and arterial compliance. However, potassium supplementation should only be done under medical supervision, especially in people with kidney disease, which is why dietary sources are preferred. Weight management also plays a significant role. Even modest weight loss has a disproportionate effect on systolic blood pressure in older adults. Losing 5 to 10 pounds can reduce systolic pressure by 5 to 10 points, largely by decreasing vascular resistance and improving insulin sensitivity. Importantly, weight loss in seniors should focus on fat reduction while preserving muscle mass, since muscle loss itself increases fall risk and metabolic instability. Physical activity is another cornerstone, but not all exercise is equal for blood pressure control after 60. Regular aerobic activity such as walking, cycling, or swimming improves endothelial function and arterial flexibility, which directly lowers systolic pressure over time. Strength training, especially involving large muscle groups, further improves insulin sensitivity and vascular tone. However, excessive high-intensity exercise without adequate recovery can transiently raise blood pressure and increase injury risk, which is why consistency and moderation are key. Stress management is often overlooked, yet chronic stress keeps the nervous system in a state of constant activation, elevating cortisol and adrenaline levels that drive blood pressure upward. Practices such as slow breathing, mindfulness, prayer, gentle yoga, and adequate sleep have measurable effects on systolic pressure, sometimes comparable to a low-dose medication. Sleep itself deserves special attention because untreated sleep apnea is a major contributor to resistant hypertension in older adults. Seniors who snore loudly, wake up unrefreshed, or feel excessively sleepy during the day should be evaluated, as treating sleep apnea can dramatically improve blood pressure control without adding medications. Despite optimal lifestyle changes, many people over 60 will still require medication to adequately control systolic pressure, and this is not a failure. It is a reflection of age-related vascular changes that lifestyle alone cannot fully reverse. The goal of medication therapy in seniors is not to chase the lowest number possible, but to reduce systolic pressure gradually while preserving diastolic pressure and preventing orthostatic drops. Doctors often start with low doses and adjust slowly, monitoring symptoms closely. Certain medication classes are particularly useful in older adults. Thiazide-type diuretics reduce systolic pressure effectively by lowering vascular volume, but they must be used carefully to avoid dehydration and electrolyte imbalance. Calcium channel blockers help relax stiff arteries and are especially effective for isolated systolic hypertension. ACE inhibitors and DRBs protect the kidneys and heart and are often chosen when diabetes or kidney disease is present. Beta blockers may be appropriate when there is a history of heart disease or arrhythmia, but they are not always first line for isolated systolic hypertension. Combination therapy is common and often safer than pushing a single medication to high doses. Home blood pressure monitoring is essential during treatment adjustments. Office readings alone are insufficient because they do not capture daily fluctuations or postural changes. Seniors should measure blood pressure at the same times each day, ideally morning and evening, and periodically check standing values. This data allows doctors to fine-tune treatment and avoid overtreatment.